Good morning, everyone, and welcome to our research round for the month of January. So this morning we're with Dr. Ivan Florez. He is a pediatrician with a Master of Science in Clinical Epidemiology. He's an assistant professor of the Department of Pediatrics at the University of Antioquia in Colombia, and currently a PhD candidate in health research methodology at McMaster University. His research interests are pediatrics, gastroenteritis, knowledge synthesis, systematic reviews, network meta-analysis, knowledge translation, and clinical practice guidelines development. He has a wide experience in international clinical practice guideline development and implementation, and he is a member of the AGREE collaboration. So welcome, Dr. Florez, and thank you for getting up early with us this morning.
Hello, thank you, Megan. Hello, everyone. So for today's webinar, we're going to make a quick talk about the AGREE 2 instruments. So I hope that you are seeing my screen right now. Is that okay, Megan?
Yep, we can see it. I don't know if you're able to make it. Yeah, that's perfect.
Okay, perfect. So I'm going to take a couple of minutes to go through the general idea of the instrument and the uses and how to use it, who can use it, and the roles of the tool. At the end of the presentation, we can try to respond some of the questions that you may have. So I have no competing interest to declare from a financial point of view, but from an intellectual and academic, I have to declare that I'm co-investigator in some degree-related projects. This is the content that we're going to cover today. We are going to talk about the background, the guidelines, what is the AGREE tool, uses, potential users, the domain items that are part of the tool, the scoring and appraisal, recommendations to use and how to score, and some words on the AGREE ecosystem, additional tools that are that already exist or are under development, and some questions that you could have that I could try to respond at the end. So what are clinical practice guidelines? Most of you are really familiar with what are clinical practice guidelines, but just as a reminder, guidelines are systematically developed statements which have the aim of assisting practitioners and patient decisions about what it would be the best healthcare for a specific clinical circumstance. Clinical practice guideline can play an important role beyond that. So even though three guidelines were created to support clinical clinical decisions, they've been used in other fields beyond the clinical encounter, the clinical decisions. As you should be aware, clinical guidelines are used for health policy decisions, funding decisions, and others, quality improvement. So guidelines have gone beyond the traditional clinical scenario and are a good tool to assist the decision in the whole healthcare continuum. So, and we can have guidelines that are going to provide recommendations not only for clinical specific decision, but also for public health and other fields that are related in health. So we can have clinical practice for a very large list of fields within health. And we can have guidelines for health promotion, for screening, for diagnosis, and the most common and the most used one is the one for treatment. So what is AGREE 2? The AGREE is a methodological blueprint to inform guideline development and requirements. So it's the most used around the world, the reliable and valid tool to evaluate the quality of clinical practice guidelines. And as you can see in the name, this is the second version, because there was a first version, and the second is the update of that version that is the one that I am going to talk about. what is the role of Agree to? So we can have Agree not only as a tool that we could use for assessing guidelines, for appraising the quality of guidelines, but the first use that we can see people are making the use of it is for development. For example, for groups who are developing guidelines, if you are part of a guideline group which is aiming to develop a new guideline in any specific field in health, you can use the Agree to guide the development of the guideline, because the Agree has a lot of items that are going to help the developers, the people who are members of that panel, of that guideline, to follow the necessary steps to do a very complete and high quality guideline. So the first role of the Agree tool is for development, for people or for experts who are trying to develop a new guideline. But also we can have Agree for reporting, and this is for just in a more advanced step of the guideline development. Groups or people who are developing new guidelines and they just finished the guidelines, they did all the process, and they need a guide to help them to report, to do the final report of that guideline, to do the writing of the guideline. It's a very overwhelming task to do a guideline and also to write the final report of the guideline. So the Agree tool has all the items that we should have in mind when we are writing the final guidelines. So not only for the development, but also for reporting. And for appraisal, which is one of the most common uses for people, potential users, people who are not developing guidelines, people who are intending to use the guideline. They want to know, they want to use a guideline, but they have a bunch of guidelines, and they need to decide whether this guideline is or are of good quality, or you have a bunch of 2 or 3 or 4 guidelines for the same topic, and you need to take the decision of which guideline you're going to use in your context, and you need to say to take a decision which one would be the best. And that is where Agree can be used to appraise all these guidelines and try to take a decision which one is the best for your context. All of the above. So Agree is for all the previous roles that I have described, not for one, but for all the 3 of them. So in summary, Agree is a tool that is very useful for developing, for reporting, and for evaluation of clinical practice guidelines, depending on what is your role. You're a developer, or you're a potential user, or even a group of people that are intending to adapt a guideline in your context. There is Agree which can help you to take the decisions in the process of which one is the highest quality guideline. So who can use Agree? So the idea of the Agree is that it's a very, even though it was a complex tool to develop, and it's a tool that is intended to be easy for users. So we expect that everyone can be able to use it to apprise with a guideline. Healthcare providers, regardless of the field, physicians, nurses, dietitians, psychologists, whatever is your field, could use the Agree. Clinical practice guideline developers, as I just told you, can use Agree as a blueprint for development, or also for guide the writing of the guidelines, and also adapters, people who are trying to take the decision which guidelines you're going to adapt in the context. Also, these kind of users are very interested in the Agree use. Policymakers that need to take decisions in the healthcare system in different fields, like funding decision, quality improvement, can use the guidelines. Educators in the academic environment to teach evidence-based medicine, to teach how to assess the best high quality clinical practice guidelines, and so on. So that means everyone could use Agree. Anyone who is interested in using or developing a clinical practice guideline, or who is teaching about clinical practice guidelines and evidence-based medicine. But it's very important to highlight that no special background is needed. So we only need to assess and to use the tool, basic knowledge on evidence-based medicine concepts, and in what is a guideline, just to have an idea of how does evidence-based medicine work, and what is the clinical practice guidelines, and also a little bit of training. It is good to have a little bit of training from people who are more experts in the tool, and also use some online tools that we have for that I will cover at the end of this presentation. So what are the content? What are the items and domains that we have in the Agree tool? So the Agree is a relatively long tool that encompasses 23 items that are clustered in 6 domains. These are the 6 domains that the Agree includes: scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. I am going to go briefly through all of them, but also wanted to highlight that in addition to these 23 items, we have 2 overall questions that are related to after you do the assessment, after you do the appraisal of the guidelines. The question is, are you going to recommend this guideline or not, or what would be the final overall score that you will provide to this specific guideline? Also, the manual, as I'm going to show you later, has a list of definitions: what are guidelines, what is appraisals, examples, where to look, how to rate. So even though this is for people who are new to the tool, this is a long tool and it requires a little bit to get familiar. The manual is very, very friendly, user-friendly, because it provides clear definitions about what are the domains, what things should be included in the items, examples of how could you do a better score of the guidelines, where to look in the guidelines, and how to rate. So this is the long list. As you can see here, we have in the first column all the domains, the 6 domains that I just mentioned, and in the second column we have the items. As you can see, some of the domains have 3 items, others such as rigor of development, which is the third domain, has 7 items, and others like the legal independence has only 2 items. Let's go one by one in the domain. So the first domain is scope and purpose. The scope and purpose is it's a domain that is concerned about how the guideline described the overall aim. What were the specific questions? What was the aim of the guideline? What was the population that the developers were interested in? So it's a general domain that tries to assess how the guidelines were framed, what was the interest, and what were the objectives when the guideline was framed and developed. This domain has 3 items. The items that you can see in the slide, the first one is about the objectives of the guidelines. So we expect that, for instance, the guideline is very clear about what were the objectives, not only of the development of the guideline, but also the final aims, the population. Not only to state that they were interested in a diabetes guideline, but also that they were interested in having impact on health outcomes such as reducing hospitalization, reducing mortality. What is the aim of the guidelines in health outcomes? Health questions are covered by the guidelines, which will be the second item, as this is related with the question that we usually do when we do evidence-based medicine, the systematic review. We expect that the guideline includes a list of questions, because each question is the one which is going to guide the systematic review of the guidelines. So it should be clearly stated the health question that the guidelines is covering. And the guidelines could have a list of 5 questions, and long and very, 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 very large guidelines could have 20, 30 or more questions, but these questions should be clearly stated and easy to find within the guideline. And finally, the populations. of interest. It was the interest of the guideline to provide recommendation for patients for the publish which was the disease. It was a specific stage of the disease. This was a specific type of cancer, or was lung cancer or final stage cancer, metastatic cancer, was diabetes for patients, adults, for children, etc. So all the descriptions about what the population was included and what population was excluded from the guideline should be clearly described in the guideline. So this is the first domain, with the first 3 items in a very general way to describe. So the second domain is concerned about how the guideline was developed in terms of people, in terms of the stakeholders and the individuals and the fields that should be there in the development, and how the guideline represents the views of the intended users. What I mean with this is when we are doing a guideline for a specific disease, we expect that the developers, the people who are developing the guidelines, are those that are going to represent all the stakeholders, all the experts that should be there developing the guidelines, and all the views of the intended user. So this domain includes 3 items, as you can see here. The first item is related to the individuals. Were individuals from all the relevant professional groups included? If I am doing a guideline on obesity, for instance, we should expect that there were, as part of the developers, all the fields represented, such as internal medicine, such as dietitians, such as nurses, such as general practitioners, or pediatricians, if the obesity is going to include children. Also, there should be endocrinologists, etc. So we expect the relevant professional groups. The 5th item is that the views and preference of the target populations, patients and published, have been sought. So that means that the guideline has to be very explicit in how the developers consider the patients and public values and preferences. Sometimes patients are part of the panel. Sometimes it is very difficult, and not in all the guidelines have patients included in the panel. But if they are not, there should be some kind of mechanism to try to introduce the values and preferences in the process. And the final item of the domain is that the target users of the guidelines are clearly defined. Not only who are participating, not only that the patients are included, but also that the target users are really clearly, which are going to be the people who are going to use this recommendation, in which setting, specifically which fields and which professions are going to be using this guideline. So this is the second domain. The third domain, which for many people is the most important one, I'm going to explain that a little bit later, is the domain related to the process of gathering and synthesizing the evidence, because the evidence is the one who is going to support the recommendation. So this has a long list of items. We have here 8 items. The items, I'm going to go really quickly through them. First, that the systematic methods were used for research the evidence, clearly stated which databases were used, where did the developers look for the evidence, where a search strategy, who did the search strategy, and what were the databases that were consulted. The 8th item is that the criteria for selecting the evidence are clearly described. So not only where to search, but also how the guidelines were, how the evidence was gathered and selected from the literature for the inclusion and exclusion criteria. Also, the strengths and limitation of the body of evidence are clearly described. It was a clear discussion about what were the strengths, what were the limitations of the evidence. Also, in the 10th item, we are talking about methods for formulating recommendation, how after selecting, selecting, and assessing the quality of the evidence, the strength of the evidence, how the recommendation was formulated, how was that step from going from the evidence to the recommendation, clearly what considerations were taken into account to make the recommendation. The 11th item is about the health benefit, the side effects, and the risk. It's about the balance between the harm and the effects of the intervention. We're considering not only that the interventions are good for health outcome, but also what were the side effects. The 12th item is about there is a specific link between recommendation and supporting the evidence. What is the link that connects the evidence with the recommendation? Sometimes there is not that link, but it should be really explicit in the guideline. The guideline was externally reviewed by experts. Is the 13th item. It's a criterion for good quality that all guidelines should be reviewed by experts before its publication, and it should be stated in the guidelines at the end. And finally, a procedure for updating the guidelines should be provided. That is very important because it will allow us to see if this guideline is still current or not. How or when should the guideline should be updated. The domain for the clarity of presentation. This domain deals with the language, the structure, and format of the guideline. We also have 3 items. The idea of this is that recommendations should be specific and not ambiguous. You should take a look at the recommendation. Are they clear? Are they concise? Are they ambiguous? If they are, they should be really very clear about what to do. The different opinions of management of the condition or health issue are clearly presented, not only what are the recommendations, but also the different options that we could have for the management of a specific condition, and the recommendations that are easily identifiable. That it's really clear, it's really key that the recommendation should be really easy to identify, to see in the guidelines, not in a long list within all the text. It should be clearly in boxes, in tables that should be easy to consult and to look for. The 5th domain is applicability. This is more about how these recommendations could be applicable in a specific context. It includes the analysis of the barriers, of the strategies to improve the uptake, the cost, etc. The items are 4. First, the guidelines should describe barriers and facilitators of its application. What would be the barriers and facilitators for those recommendations that are in the guidelines? Also, the guidelines should provide some advice and or tool of how the recommendation can be put into practice. Also, we expect that the guideline make a discussion about the resource implication of applying the recommendation in the context. And also, the guidelines should present some criteria for monitoring and auditing, which is very important for people who are going to implement that guideline. What would be the indicators and what would be the way to make the audit. The final domain is editorial independence. This domain is concerned with the formation of recommendations that are not being unduly biased by competing interests. So there are 2 items only. The first one is the views of the funding body have not influenced the content of the guidelines, and also so that the comparing interest of guideline development group has been recorded and addressed. So the guideline should include the competing interest, which is the final item, but also it's very important to assess if those competing interests or if the funding body have not influenced in the content of guidelines. So now that we know a little bit about the domain and about the content, how do we score the agreed to? So the score, the agreed to, is based on what we call a Likert scale. A Likert scale is a continuous score that goes from 1 to a specific number, in this case from 1 to 7, in which 1 on the left is where you're going to respond where you are strongly disagree with that statement. And the 7th is the maximum score that you're going to use when you are strongly agree with that statement. So usually for the guidelines, a score of 1, I strongly disagree, means that there is absence of information, so there is no content relevant about the agreed item, or if the content is very poorly reported. So we have to apply this for each one of the items, each one of the 23 items. So if the items, when we are looking for the information, there is no information, there is no content, or the content is very poorly reported, we are going to use 1. And on the other side, when the item, when we are looking at the guideline, the quality is exceptional, it's very clear, it met all the criteria and considerations that are articulated in the manual, all the considerations are met, then we use the 7. So it's really easy. Usually the 1 and the 7, the most difficult ones are in the middle. So you have to choose between 1 to 7 to see what would be the degree of agreement that you have with this item. Has this item accomplished the expectation? Has this item met the criteria? So you have to choose. And this is a subjective, of course, measurement, but it's a way to try to give more objectivity to the score. And as I'm going to show you, you are not alone in this. There are going to be examples in the manual. There are going to be some guidance on how to score the best in each one of the items. So you have to choose from 1 to 7. So each guideline must be assessed for a minimum of 2 reviewers, and reviewers' scores for items within each domain are combined together, and we are going to obtain an overall domain score expressed as a percentage. The formula can be found in the Agree 2 instruments I'm going to show you. So how this works, as I just told you. So we expect minimum 2, and Agree also recommends to 4, maximum 4 appraiser. So in this case that you have in the slide, we have a guideline that was assessed for the first domain, domain 1, for scope and purpose, that was assessed by 4 appraisers. The item 1, item 2, item 3 for the first domain were scored. And as you can see, the appraiser 1 gave a 5 in item 1, a 6 in item 2, and a 6 scoring item 3, and so on for the rest of the appraisers. And each one has its own score for the whole items, the 3 items. And we're going to obtain a final score for each one of the appraisers and a final score for each one of the items. So this is calculations based on this. We're not going to do it right now, of course, but from a maximum possible score, and this is the formula and the equation, based on this score in this equation, we're going to calculate a domain score. So for these scores that you can see here, in this example, this domain, the domain 1, scope and purpose, for this guideline that was appraised by 4 people, obtained a 57% of a maximum of 100%. Based on the scores of the appraisers. So this is how we do. So we're going to obtain in each one of the 6 domains. We appraise 23 items, but we are going to obtain 6 percentage, 1 for each one of the domains based on each one of the appraisers. You can do this also for 2 appraisers. This is an example that we can find in the manual of the Agree. And this is how you see the manual in the Agree 2. You're going to have at the top the domain, the question, the Likert scale from 1 to 7, and the comments if you want to provide more explanation and a rationale why did you score. The manual description, as I told you, the user's manual description is going to provide you all some example of how to score, where to look. Also, the manual provides you information of in which part of the guideline should I look for information to appraise or to make a scores in this domain, and how to rate, what criteria you should have in mind when you are going to make the score and additional considerations. So as you can see, there is a lot of guidance in the manual that will help you to make the score if you are applying Agree for the first time in each one of the items. This is an example of the second question, scope and purpose, but it will be similar for the all 23 items. And as I told you, there are at the end 2 final questions. The first one is, after you make all the scores, what would be the overall quality of this guideline from 1 to 7, being 1 the lowest possible quality and 7 the highest possible quality. And second question would be, second final question, would I recommend this guideline for use? Yes, yes with modifications, or no. So how to apply? So you can do manually, that means with the PDF, score and manually, and just to write what are the rationale and make the calculation by yourself. Some people create Excel scoring sheets that include all the formulas and equations, and you can have the final percentage at the end. Or even easier, you can use my Agree Plus that I'm going to show you. The Agree manual is the way that you can use it manually. Yes, it has the definition of each item. It has examples I just showed you where the information can be found and criteria and consideration to use. So it's really easy to apply. It's a little bit more of work if you do it manually, but all the information is in the manual. Or you can use the Agree Plus. The Agree Plus you can find in our website, which is the www.agreetrust.org. In the website of the Agree, you will have not only the original tool, but also all the papers that supported the process of the guideline, the full development, and also you can find additional tools that are under development or have been developed. I'm going to show you. This is the platform, as you can see. Within the Agree Trust, you go to the Agree Plus, my Agree Plus, and you create a username for you and a password. And you can use it for accessing guidelines online. So it's relatively easy to do online, and we'll do all the process of calculation for you. You can do appraisal for guidelines among several people in different places. So this is how you can see the Agree Plus. How do you assess each one of the items, and what is the comments, and how do you score in the platform? How do you interpret the scores? You have all the scores at the end, so you have to identify the scores are useful to identify strengths and limitations of guidelines, to compare methodology and quality between guidelines, and it will help you to select high quality guidelines for adaptation, endorsement, or implementation. The one very important point to highlight is that there are no magical threshold or range of scores to determine which one of the guidelines is like or so. And there's no evidence that okay, if you have a score of more than any threshold, it's going to be high quality, or you have a score below that threshold, it's going to be low quality. So we don't have that because there is not evidence to say that a specific score, 40%, 60%, 65%, or 80%, means that the quality is so good that at the end is going to be related to better outcomes for patients. So you use the percentage as a guide, but from the Agree, there's no recommendation of specific threshold. So examples of how you could interpret the score. You can prioritize one domain and create one threshold. Usually, the domain 3, which is related with the methodology, the one which is more used and the one that we used. So domain 3, the rigor of methodology, if we establish a threshold of high quality above 70%, that's a good way to try to define what would be for you a high quality. This is not based on anything. This is just a random threshold. So you define, for instance, 70%, you could take a decision of which guidelines are you going to use. Or you could appraise by stages. That means you can, if you have 20 guidelines to assess for the specific topics, you can apply as a filter. The domain 3, if we have a domain 3 as a first step in all the 20 guidelines. Only those guidelines that got more than 70% in domain 3 will be assessed with the rest of the items. That's a way to be more efficient in the process and not to apply the whole tool for the 20 guidelines, which will be a very overwhelming task. Or you can consider all the domains. In this case, if you assess all the domains and do the scores of all the domains, you can get a decision, for instance, all the domains needed to be more than 60% in order to consider a guideline of high quality. But you can also choose 50%, but you can also choose 70%. So that's a decision that you have to make in advance before you're going to apply the guidelines. What would be your threshold? What is the threshold in your organization, depending on the context you are working, before assessing and take a decision what's going to be your high quality guideline. Or you can do threshold for improvement over time. Organizations do this all the time, trying to make a continuum and say, okay, we're going to assess our guidelines in 2010. We will compare the score of 2010 with 2018 to see how the scores have been improving all the time that we're improving the method. So this is a some example of how to interpret the scores and degree. Here's an example of a random guideline. In this case, we have 3 guidelines that we assess, and these are the 6 domains. And as you can see, in green are all the scores that were above 70%, and in red were all the scores that were below 70%. So as you can see, of these 3 guidelines, there are different scores. The clinical practice guideline, for instance, got 0% in editorial independence. After I can take a look of these scores, I can say, okay, of these clinical practice guidelines, but that are for the same topic, I can choose the clinical practice guideline 3, which because it was the one which has the highest scores, and the rigor of development was 90.3%, which is means that the methodology was really, really good performed in the guidelines. So even though I have one domain that is below 70%, as I told you, there is no specific magical threshold, but this is a clinical practice. Third clinical practice guideline is a good guideline that I can use, and I can trust more than I would trust in clinical practice guideline 1 or clinical practice guideline. This is an example of how to do the score and how to take a decision of which guideline you're going to use. So what domains? Usually the domain 3, as I told you, is the preferred and most valued domain because it's like the core of the method, it's the core of the evidence-based medicine. If we have a good scoring here, means that the method was really very, very good performed. So I can trust you. I can trust in the guidelines. And the editorial independence is a very, very interesting domain. You only have 2 items, but it's related with trust. How much do we trust in the guidelines beyond the method? Did the funders have an impact on the recommendations? So the editorial independence is a good one that we can use for a second domain to have a threshold. And the applicability to domain 5 would be a little bit more flexible because the applicability is usually assessed based on the context. So there are guidelines that are going to be applicable in one context and may not be applicable in other contexts. So maybe sometimes we can be a little bit more flexible, and a lot of guidelines don't routinely include the applicability or the implementation part, which doesn't necessarily make the guideline is bad quality. Sometimes it will require some modification to be applied in the context. Sometimes you, as a user, will need to do all the implementability and applicability and create indicators. So applicability would be like more flexible depending on what you work and depending on the user going to do to the guidelines. So are you concerned about the training? Is this a lot of information? Yeah, it's a lot of information, but no worry. Take a look at the Agree Trust page, and you can have some tools for training here and tutorial that will help you to get to start if you are not familiar with the tools, and will help you with your first assessment. Agree has some limitations and do not assess clinical content. So we are not going to, well, when you apply the tool, you're not going to say if the tool was clinically relevant or not. It's more about the development, it's more about the applicability, and it's more about the methods. And also, the Agree do not assess the quality of evidence that supports the recommendation. This is not a tool to assess how the quality of evidence that supports the recommendation of the guidelines were done. There are other tools and other ways to know that. Usually, the GRADE methodology, for instance, is a way to organize the process of how to synthesize and how to assess the quality of evidence that supports the guidelines. And also the rolling appraising guidelines tackling healthcare system organizational issues and health technology assessment has not been evaluated, even though we think that there could be a very important role in that. And there is another tool that we recently created that is going to be launched soon, which is the Agree HS, which is a tool that comes from Agree, but is more focused on how to assess the quality of health system guidelines documents. And this is a final word for an additional tool, which is the Agree GRS, which is a very compact, small tool, like a little Agree. It's a global rating scale, very short, that is related to the Agree, of course, and only includes 4 domains, as you can see: quality of guideline development, quality of guideline presentation, the completeness of reporting, and the quality of guideline recommendations. And overall question. So it's a reasonable alternative for clinical practice guidelines assessment, especially in circumstances when time and resources are limited. But it's not going to replace the Agree2 tool. The Agree2 tool is the best one to assess a good, complete guideline. It has it's valuable, and it's reliable. The Agree GRS is an option when resources are limited, you don't have time, and there is no it's enough time to make a decision, or you don't have too much time to apply the whole guideline. And coming soon, there is the Agree-Rex, a new domain, a new tool that is intended to assess the credibility and implementability of recommendation, trying to go beyond the method. It's going to be soon released and launched this year, we hope. So there is an Agree ecosystem, as I told you, and the Agree is related with all these tools that you can see here. First is what the Agree, then we got the Agree2, which is I just described. We have the My Agree Plus, which is the platform to apply the Agree, and we have the Agree GRS, as I told you, the Agree-Rex, which is coming soon, the Agree HS, as I told you, for health system guidelines document, and there is Checkup, a new checklist to assess the reporting, only the reporting of updated guidelines, and the Agree checklist, which is a good guide to guide the reporting of the guidelines. So there are a lot of tools that are here, and you can look more in depth to them in our website. So those were my slides. These are the social network, the email, and all the way that you can contact us, and you can access to all the information that I provided to you in our website, www.agritrust.org. And I am happy to try to respond to some of your questions if something was not clear. Thank you very much.
Thank you, Dr. Florez. Maybe we could just hang on for a minute and give people a chance to think about if they have a question or not, and if they can they need a minute to formulate that question. I'll also let people know that we have applications open now for the KT Canada Scientific Meeting. That's happening in June in Vancouver. And so if you would like to submit an abstract for that, applications are open now. So you can go on the KT Canada website for that. I think they're open until February 12th. And if you have any questions, you can email me, Megan. Okay, so we have a question from our site in Toronto.
Hi, this is Chantal. I was just curious because it seems like the Agree2 was published in 2009. I guess part one would be if you foresee another major update to this or if it's working well, and the part two would be how well has this been used by researchers, clinicians, etc.
Thank you, Charlene. So the first question, the Agree was 2009, and the Agree2. And I can say that there has been an incredible uptake of the tool around the world. Agree is definitely the most used tool around the world for clinical practice guideline appraisals, not only in the clinical environment, but also in the health systems environment and also in the research environment. There are the Agree2 paper has been cited more than 1,000 times, and there are a lot of research that is based on the quality of guidelines, and they are using Agree. So in general, the uptake has been really good.
That's great.
In terms of the update, we are not thinking, and we have not kind of aiming to update the tool. The tool works really well. Of course, it's not perfect, but based on the may I say, the weaknesses of the agree in terms of the limitations? Not the weaknesses, maybe the limitations. As I told you, we are not assessing the credibility of the recommendation. So most of the concerns with the agree have been related with the credibility of the recommendation and implementability, that this tool does not really capture how credible are we going to be in the recommendations. So because of that, the new tool was created. Rather than updating the agree tool, there was a creation of the new tool, which is, I mentioned to you, which is the Agree Rex, which is focused only on the recommendations rather than the whole guideline. And the Agree Rex is intended to assess the credibility and implementability of the recommendation. And we did this based on a survey and based on a review of the literature, and we asked developers around the world. And the final idea was that people were more concerned now, not about the method, but about the credibility of the recommendation. So for those limitations of the agree, the other tools that I showed you briefly in the agree ecosystem are trying to complement. But no, we are not thinking about an update of the agree right now. That responds to your question, or you have another thing else?
Oh, that's great. It seems like then the others, I don't know what you call them, they're essentially extensions to the agree to specifically address those concerns, like the recommendation one.
The question is they are extensions or not. That's a good question. The agree regs is a kind of complement. So sometimes if you want to take a decision about what guidelines is better than the other, in general, agree would be the best tool. But if you're going to use that guideline, trying to use it for implementation or to adapt that guideline for your context, we think that Agree Rex would be that tool that you will use, which is a really shorter tool, and will help you to take a decision of what recommendations are going to be more implementable in your context, if you need to adapt them or not. So Agree Rex kind of complement, but the other ones like Checkup or Agree HS are in different fields. For instance, health system guidance documents, which is kind of related, but is a different field. And Checkup, for instance, is a checklist only for guidelines that have been updated. Yeah, they kind of complement rather than create a new super tool trying to take a decision on which tool do you need for which specific purpose.
Sorry, Dr. Florez. I don't know, you were cutting out a little bit during that part.
Which part? Sorry, when I was explaining the complement.
Yeah, it's still a little bit cutting out. Did you change anything with your microphone?
I didn't change. Maybe the internet. Want me to repeat?
It's okay. It seems like there's maybe I'm not sure. Maybe it could. Yeah, it's just a little bit choppy. Like we can kind of hear you, but kind of it's not super clear.
So you did address my comment or question earlier, so thank you for that.
Okay, and we don't have any other questions coming in from the individuals. Jen has a question with us here, though.
Oh, hi, Dr. Flores. Thank you for a really informative presentation. I guess my question is more directed at people's experience and your experience in using the tool. I know you said that it's not really meant to address the clinical content, but based on, you said it's been cited like 1,000 times. So based on all the times that it's been used, what is your impression, or have you done a study to look at this, of how people, if there's any systematic way that people go about assessing the clinical content of the guidelines?
That's a very difficult question. But the problem with the clinical context is that it depends on the field. It depends on each disease. So it's very difficult because each disease is going to have special factors and a specific context. So when I am trying to say that it's not going to, the tool is not going to assess the clinical content, is that the good line, that a clinical practice guideline could be really, really good with high quality methods, and at the end, the recommendations are not going to be useful from a clinical point of view. And that is one of the factors that we are intending to address with the new AgriRex tool, which is kind of, it's not going to respond the question that is clinical relevant or not, but it's going to help you to think about how clinical is this recommendation going to be, how relevant it's going to be for the patients and for the clinicians that are treating patients like this all day, every day. So clinical users, clinicians, sometimes are going to tell you, okay, that guide is really good, but it's not going to be useful for me for any specific reason. So that is why it's very helpful if you can try to, when you apply the degree, also have an input from a clinical expert in your field. That will be only useful not only to see the method, but also to be the clinical relevance. So it's very difficult. Hello?
Okay, yeah. Thank you.
Okay.
Okay, so I think that's
sorry, Megan, just to add to the citations that that was described, the citations in the papers are mostly related with from the methodological point of view to the analysis of guidelines that are published by the most important organization, WHO, NICE, Cancer Care Ontario, etc. So most of the citations are related to from an organizational point of view rather than clinical point of view. So the clinical input in a guideline is very important. So I agree trying to fill the gap of the method quality assessment, but also the expert, the clinical expert, are very important in taking decisions about the relevance of the guidelines in a specific clinical setting.
Okay. Thank you very much. So I think we're all set. I don't see any other questions coming in. So if anyone does think of a question later, you can always email it to me and I can get it to Dr. Florez, or you could email him yourself. But thank you everyone for joining us, and thank you especially Dr. Florez for that very informative presentation.
Well, thank you very much, Megan. Thank you very much, everyone, for listening.
Okay, have a great day, everyone. Take care.
Bye. Take care. Bye-bye.